Okay, all right, we'll get started. So this is just an adaptive talk I've given to a couple different audiences about immunosuppression and heart transplant, but a lot of the concepts apply to other organs as well. We share a lot of the same sort of foundational pieces of that. It's just like the nuance. The other thing I'll say as well too is that transplant is significantly different at every single center. So if in the future you ever went to like Temple or Jefferson and saw heart transplant, they would do things a little bit differently there. It's sort of the nuance that everyone incorporates in the absence of, honestly, any really great data. We have to drive a lot of this outside of a few different components of it. So these are my disclosures. I don't have any money from anyone, unfortunately. And we're going to talk about non-FDA approved medications and or uses in medications because not many of the transplant medications are actually FDA approved for transplant in heart. So I just want to review immunosuppression concepts and basics in heart transplant, and then review some of the pharmacology and clinical considerations for our maintenance immunosuppression regimens. So first I want to set up a framework to sort of show you how we think about immunosuppression altogether before we go into the specific agents. Excuse me. So this is a timeline that outlines the development of the different immunosuppressive agents we utilized. And what's interesting is if you look on the left over here, starting in the 1950s when we first approached organ transplantation in humans on an experimental basis, we had really bad drugs, to say uneloquently, for use in transplant. They were super non-specific. We gave high doses that were extremely toxic. And while we got people through the immediate perioperative period, they oftentimes had poor outcomes and lived for days, if not weeks, maybe a month or two before perishing, either from complications of the transplant itself or complications from medications we used. This all changed in the early 1980s, late 1970s with the development of our progenitor first calcineurin inhibitor called cyclosporin. And this was the game-changing medication that came out that really has allowed us to have transplantation as it exists in the modern sphere. Before this, the outcomes were not good. We really couldn't offer this as a therapy to many of the people. And since then, this has come into the mainstream then as like the recommended therapy for end-stage organ disease across multiple different organs. Later on, we had tacrolimus and then eventually mycophenolate. And you'll see that was in the early 1990s, late 1980s. And since then, this has been honestly the best regimen that we've been able to develop and find for prevention of rejection and sustaining good outcomes longer term in transplant. There's a smattering of other agents thereafter that we've attempted to use that either are equivalent or have been shown to be inferior in terms of long-term survival of these patients. So it's quite fascinating to me that a regimen we developed 30 years ago still is sort of the gold standard for everything, despite our best efforts to develop something a little bit better. In terms of immunosuppression itself, we use different amounts of immunosuppression based on the organs we're transplanting. So there's some organs like liver on the right, which we can give extremely minimal amounts of immunosuppression. And because of properties of the liver itself, it is at less risk of rejection. There are some liver transplants far out that even can come off immunosuppression at certain points and have no difference in outcomes. This is contrasted with things in the thoracic cavity, like heart and lung, that require huge amounts of immunosuppression. And then small bowel, which is sort of an outlier here because of the amount of lymph tissue we transplant. And so we have to give them high levels of immunosuppression because they've had such high risk of rejection overall. And then this is the degree of immunosuppression over time. And this isn't true for every organ, but this sort of gives you an idea of what it looks like when patients come for readmission for different complications. But we have this initial phase in which we administer what's called induction, which is high doses of immunosuppression to achieve this net immunosuppressive state initially and reduce the risk of rejection in that early period. We then have a maintenance period in which we have peak immunosuppression around 3 to 6 months post-transplant. And then there's a slow decrease in immunosuppression between 6 and 12 months. And then thereafter, as patients better tolerate the new organ and the total inflammatory state from the time of transplant decreases slowly. So again, for your heart readmissions, this sort of, you can see is why they come on wildly different regimens and doses of things based on where they are from their transplant. And this sounds overly simplistic, but this is the balance that we try to achieve in every single patient. And that with immunosuppression, it's a giant balance. And we don't want it to swing too far in one direction where we decrease it and they have risk of rejection, but we can't go too far in the other direction in which there's risk of infection, side effects from the medication, and malignancy. And this balance is somewhat more or less difficult depending on the patient and sort of how they're presenting and things like that. But this frames essentially every discussion we have about changes to immunosuppression in our patients. There are other factors affecting this. I won't go into great detail with a lot of these, but There are different things that can sensitize a patient pre-transplant, including the amount of blood product they get. If they've had prior pregnancies, that can impact outcomes post-transplant as well. If they've had prior rejections, and then also different things like age. We know folks who are older probably have a lower risk of rejection for reasons we don't fully understand. Ethnicity can impact it also for reasons we don't always fully understand. Part of the data for that is in the mycophenolate trials, in which patients who identified as African American or Black required higher doses of mycophenolate to have similar outcomes as other groups. And so it's unclear if this is a metabolic issue or something else going on, but there can be subtle differences there. Also, a patient's like phenotype in terms of their history, right? If they come in and they've been infected for years and have issues and have all these malignancies before they're even transplanted, that tells you a little bit something about the relative need for immunosuppression post-transplant. And then also other comorbid conditions that may affect that. So in terms of maintenance, there's a huge number of different medications you may have seen. And I think of them as different building blocks we put together to sort of form the regimen for our patients. But the three most common agents and the backbone for heart transplant at our center is tacrolimus, mycophenolate or mycophenolic acid, and then corticosteroid use. And this is like the recipe I built for how we think of immunosuppression in our patients for those on triple therapy. So our first choice is always tacrolimus or mycophenolate. And that again is because we have data demonstrating that as opposed to cyclosporin or azathioprine, these are better drugs in terms of outcomes post-transplant. And so anytime a patient is on cyclosporin or azathioprine, the question is always why? And it's typically either because they were transplanted in an era in which that was a standard of care, so like the 90s, to be honest with you, or they've failed the other medication because of intolerance. And so it's always the first question we ask ourselves. And then lastly is the corticosteroid. Corticosteroids are a little bit more difficult to parse out because the data is not as clean. We know that some folks require it, but we're not always good at picking the folks that need to stay on steroids longer term or not. So you will see some patients who just aren't on a steroid because they didn't require it post-transplant for longer periods of time. And mechanistically, the way I think about these is with our calcineurin inhibitors and antimetabolites, we're targeting our lymphocytes, so broadly T cells and B cells, okay? And then steroids, my past mentor lovingly called it like putting a blanket on fire, has a multitude of different effects throughout the body to decrease inflammation and immune activation. There's also a class called mTORs, which are kind of also difficult to throw in here because they can replace any single piece of this or sort of serve as the entire regimen overall in a select number of individuals. So starting off with calcineurin inhibitors, these prevent activation of T cells, all right? The tacrolimus products are Prograf, which is the IR capsules we have here inpatient. There's also Astigraf, which is not on our formulary, it's a longer acting formulation. And then Varsis, which we do have on our formulary, but we use very sparingly. So you probably don't encounter this too often, but it's the once daily formulation we have available in-house for our patients. There's also cyclosporin, both modified and unmodified, and you see the brand names there. The quick history with this is that cyclosporin, when it first came out, was the unmodified or the original version. And it's this oil-based thing. It had really variable absorption, folks. It was really difficult to predict kinetics. And so they created this microemulsion that we then called modified later on that was more stable and more easy to utilize for a patient management standpoint. And so my other little pearl for you folks is if you see someone come in on cyclosporin unmodified, that's also a giant red flag because they were either transplanted in the late 1980s or someone ordered and prescribed the wrong cyclosporin product. So we've actually been trying to get that unmodified off the formulary because it's just not used very often and it's a high risk for error. The two are not interchangeable. Comparing the products a little bit, I put the dosing up here, but basically we start at a low dose and then up titrate based on the therapeutic drug level. I'll show you what that looks like in a picture in a second. For the tacrolimus, there's oral capsules and suspension. The difficulty here is that tacrolimus is a really finicky drug. And so when you change from the capsule given orally to a suspension to even give it sublingual or IV, they're not necessarily equivalent like we would think of other medications like mycophenolate, right? You can kind of interchange and not worry so much about differences in kinetics, but tacrolimus is not like that. And so even subtle changes in the way we administer it can lead to significant changes in the overall levels and the effect we see of these medications.
Well, it's interesting because I don't feel like they changed the dose when we gave NPU people.
The sublingual, yeah. So that's my next point. So it depends. Okay, so oncology, this is very controversial. We have data suggesting that the conversion between oral and sublingual is anywhere from 1 to 1 to 1 to 4, okay? The nuance is that when you give it sublingually, it's actually absorbing in that mucosa and it's bypassing a lot of the metabolism you would have otherwise. So we know we have to give less of it, we just don't know how much less of it. So oncology here does 1 to 1, transplant does 1 to 2 or a 50% reduction. And so we always caution folks up here that, you know, if they're emergently in Q overnight or something, giving that same oral dose sublingually is kind of like doubling their dose. And so it's always sort of like a thing that comes up. I don't think it's part of the training necessarily. It doesn't come up super often. So it's something we deal with from time to time, but anyway. And then the IV, again, as compared to other medications, it's extremely difficult to use. We use it in transplant as a continuous infusion. The dosing is difficult, the kinetics differ in ways we don't fully appreciate, and so we avoid it at all costs. Again, sort of differing from other things that we're happy to use IV if we need to. And then cyclosporin, because it's like this oily suspension, you can't give it sublingually, so you're stuck sort of giving it enterally, or we are forced to give IV from time to time. Okay. And then again, I just noted here that none of the products are considered necessarily interchangeable. So anytime we're moving between things, we have to account for differences in that. In terms of side effects, cyclosporin, interestingly enough, can cause something called gingival hyperplasia, which we don't see as much anymore because we just don't use it. It also can cause hirsutism or hair growth across our patients, whereas TAC can actually cause alopecia. So a little bit unfortunate. And then with both the medications, they can cause nephrotoxicity, which I'm sure you know about. This can be both a dose or trough dependent effect as well as a chronic effect. So even if you've had perfectly therapeutic levels for 20 years, the exposure itself can induce some nephrotoxicity. Whereas if you have someone who's fresh post-transplant and they come in and their level's 25, that may be causing some renal dysfunction because of that. With TAC, we also can see neurotoxicity. This presents on a spectrum, but most often as patients with tremor. And so especially within the first year when their levels are higher, you'll see that they're have like a mild tremor with intention, like using your phone or eating or things like that. There can be some metabolic effects that are important to know about. And then of course the other is issues with electrolytes. So our patients oftentimes have issues with hyperkalemia and then hypomagnesemia, which is why you see on the readmissions that they're always on some oral magnesium and require constant rotation. mTOR inhibitors are a second class that we don't use as often, but these basically function to slow the cell cycle to prevent proliferation of lymphocytes as well as other different cell lines. There's two products, sirolimus, which is our preferred product post-heart transplant, and then everolimus, which we do see from time to time. And what's interesting about mTOR inhibitors is we've never really found a solid place for their role in therapy. So when they're first developed, we tried looking at all these different ways to try to replace our calcineurin inhibitors like TAC, right? We said we have this new thing, maybe it'd be less toxic, maybe we can add it on in some way to achieve better outcomes. And it hasn't necessarily across the board been any slam dunk in terms of replacing any one single agent. And so what we found is these very nuanced little roles of it. So in heart transplant, most often it's to prevent or treat chronic rejection, which is like that fibrosing allograft vasculopathy, that fibrosis of the different vasculature coronary arteries. We also see it for some cancer indications, and then also we will from time to time try to replace TAC with it. The issue is that it comes with a higher risk of rejection, and so we're always very cognizant of that. What's interesting about this is it's only oral, there's no IV. And then the other interesting part is that it has a super long half-life. So it can cause issues when we're making dose adjustments or checking levels or trying to hold doses, that it sticks around for an exceptionally long period of time. And why that's important is because it impairs wound healing. And so if patients come in for an emergent operation of some kind, then we have to hold this medication, but recognize with a long half-life, it's still circulating. We also, in our patients, will hold it for like weeks at a time before procedures because of the risk of wound healing. It can have issues like frank dehiscence at the different anastomotic sites, and so we have to be careful. It can cause profound hypertriglyceridemia, like triglycerides in like 500, 600, 700s, and then also proteinuria. The last interesting piece about this is it can cause ulceration throughout the gastrointestinal tract. And so it is not commonly seen at the doses we use, but we will have patients with different ulcers in their mouth that we have to give them, like topical corticosteroids, for instance, to help treat, to keep them on that therapy. Our animetabolites broadly inhibit the replication of T and B cells. These are things you're familiar with. So mycophenolate sodium, and azathioprine. We'll talk about the differences with these in the next slide. Cellcept is the original agent, and it's most commonly used. It's available in all the different oral formulations and IV. Myfortic was developed in an attempt to help decrease the GI side effects associated with mycophenolate. It's a change in the coating around the tablet, so it dissolves in a different part of the stomach. It turns out that really didn't help at all, and the GI toxicity is just from exposure of the drug itself. Like you could have GI toxicity with the IV. So we will have some patients on this from time to time. There's no differences in efficacy, and so it's not a big deal for us to switch to this. But the important point for you folks to know is that because it's enteric-coated, we can only give the tablets, right? But we'd have to convert to the other formulation if they come in with nausea and vomiting and have to require IV or something else. And then there's azathioprine, which you do see from time to time. This one's interesting because it's actually a weight-based medication, and so the dose you see in the medication profile is actually based on how much they weigh, in increments of 25 or 50, and then it's available in obviously oral or solution or IV. The big side effects, and again, I'm sure you've seen this, is with gastrointestinal intolerance. This tends to be dose-related, but can just be the medication no matter what. So because we know that outcomes are best with mycophenolate, we try to preserve this for as long as possible. So we'll have them take it with food. We may decrease the dose. We could even spread it out from Q12 to Q8 dosing to try to help them a little bit from that. But that does tend to be a dose-limiting effect for a lot of folks. And then hematologic is the other big issue. So with both mycophenolate and azathioprine, you can see broad cytopenias that are typically responsive to dose. This is just outlining a huge drug interaction that we have readmissions for, but febuxostat or allopurinol with the gout agent, lowers uric acid. It inhibits a step of allopurinol metabolism and causes toxic levels that can cause bone marrow suppression to the point where they require Neupogen rescue and then 4 to 8 weeks to have any recovery and their neutrophil and white blood cell count. So it's really impressive. We had an admission last summer for that one of the year. Delaware PCPs prescribed him allopurinol for his gout, and then he came in and his counts are still recovering. So then there's steroids, which sort of do everything, right? They have a huge number of different targets in the immune system. We have prednisone and methylprednisolone. Something with this that you'll see is that the prednisone is not one-to-one with methylprednisolone. It's like a 20% reduction basically. So for 30 milligrams of prednisone, it's 24 milligrams of methylprednisolone, which is why you see those changes on the medication profile when we interchange between them. Oops, I'm so sorry. And then just some big side effects with this, the higher doses of corticosteroids. So for patients on a rejection treatment with methylprednisolone 500 milligrams, it can cause psychiatric effects. And we have seen this in a number of folks. It can be subtle, like racing thoughts, insomnia, and can be overt, like psychosis and visual and auditory hallucinations, but something we do see from time to time. And then, of course, profound hyperglycemia. So we typically have patients start on sliding scale if they do require the higher doses for rejection. Oh my gosh, I'm so sorry. This keyboard is, I wonder if I can. I'm giving away all my fun slides here. I just wanted to talk really briefly about the levels we check. So it's called therapeutic drug monitoring. And the reason is because there's a very small window for how much the medication we give that can be toxic or not. And there's high inter-patient variability, which means that all 4 of us in the room would have different doses to achieve that narrow range of levels required. Not sure what's happening. I'm so sorry.
So you really go to the right side. So ideally, I'd like to be on the other side.
Does someone else have the screen? This is so.
Right, like me.
I know. I'm so sorry. Okay, the people. Guess let me just double check that I'm still sharing my screen. Maybe? Okay, that was bizarre. All right, anywho, because of this, we have to check what are called trough levels in all of our patients. All right, these levels vary dramatically based on the type of organ you use, the agent, and then their other immunosuppressive regimens. You can see here, there's huge number of different goal ranges we use. And then for heart specifically, ours are per protocol 10 to 12, 8 to 10, or 5 to 8 based on their first, second, and third year after the transplant. So what influences this goal, which is the same balance that we talked about before, right? The relative risk for rejection and infection. However, in heart transplant, the difficult part of this is we don't have an easy biomarker to use inpatient to know what this means. So in kidney, we have like creatinine. In liver transplant, we have liver function tests we can look at easily to see early signs of rejection. In heart, we don't have that. If someone comes in with volume overload and shortness of breath because of the decrease in function, they're pretty late in the game in terms of their presentation for rejection. And oftentimes it's asymptomatic or may even be an intermittent atrial arrhythmia that's not always detectable on admission. So in terms of the trough levels, what we mean by this is if you look at, you guys are done right now.
You're done?
No, like the slides keep jumping all over the place. All right. So this is a pharmacokinetic curve. And what this shows is the concentration of the tacrolimus over time, all right? The green curve is the IR tacrolimus, which is inpatient. And so you can see we give a morning dose, there's a peak, and then highlighted in the box is that trough level that we're actually trying to check. And then subsequently a second peak in the evening and a second trough. And this is why we get so intent on the timing and when the level was drawn and when the dose was given and what that means, right? Because you can see if we draw the level too early and you move to the left, it's going to look higher than it actually is. If we draw it too late, then we're going to move to the right, and it's either going to be not a true trough or it's going to not be, it's going to look lower than the level actually is. And so this is why the timing of tacrolimus is something we all talk about so much. And then this just shows the second trough period after the evening dose. So the last piece I'll say is that tacrolimus and everolimus are exceptionally sensitive to a huge number of different drug interactions, particularly with our antifungal agents. And there's a few other more specialized types things we don't see as often. But this is also why we have to do a lot of creative dosing that you might see when someone gets started on voriconazole for the first time, or diltiazem, or something like that. Okay. So I guess that was the last slide. But any questions about any of that? I guess I can like chat in the group to see on the Teams. Or do you have the Teams up right now? I can open it. It's slow on my phone, but I'll pop in. No, that's okay. I'll join it. I just want to make sure if anyone has questions. Do you folks in the room have any questions I can answer for you? No? Okay. I don't know if I know how to chat. Oh, I'm presenting, so I don't think I can look at the chat, actually. I don't know if any of you are able to join. I'm not sure if anyone in the room.
Oh, that Teams thing.
Yeah, I'm sorry. Oh, no, I can do it. I'm just an idiot. Any questions about like patients you've seen and why we did certain things, or something that didn't make sense, or?
For like the sublingual stuff, yeah,
Yeah.
I mean, like they don't even absorb it. Like I remember Leslie. Do you remember Leslie?
Misdibular, yeah, I know.
Yeah. We like couldn't even get it under her tongue when she was so out of it.
Yeah.
So it's like, and then she's like spitting it out.
I know.
And it's like, like where the hell?
Yeah.
So, like, and then you said you never give it IV, not even in CT SICU?
Like I've been here 2.5 years, I've done it twice.
You've given it twice, I
Yeah,
think? Okay.
yeah, so it's just exceptionally uncommon.
Yeah, that was like fresh transplant?
No, so they would have to be readmitted and then have no enteral access for for anything, right, which is not typically common. They'd have to be intubated with an ileus maybe, and then we'd be forced to use IV, but then even then we would still try to do sublingual in some way.
Right, I got you. And then you said there's a better outcome for older people?
No, just that older folks may have a reduced risk of rejection.
Oh,
So and
that's
that's
interesting.
Like kids are so resilient. Like
Yeah.
I mean, like, this is not really database, but
The T
there's something to
cells?
be said about like a younger immune system that may be more robust. It's the same reason like when we vaccinate, we see higher rates of seroconversion in younger folks versus older. They just can't respond as well.
Right.
Yeah. So the sublingual, you're right. We've had before. I have someone in NICU right now that has like a salivation issue. And so we just can't get them to absorb enough onto their tongue to have any meaningful impact. The issue with the suspension is that it's homemade and it's a really it's called lipophilic, so it's kind of like this sticky thing.
Yeah.
So it binds to the tubing. And so you
Oh.
give the suspension and then it binds, and then
Right.
you saturate, and then the level spikes at some point. So it's just very erratic and unstable from a
Right.
dosing standpoint. And it's not available outpatient commercially.
Uh-huh.
So it's not, it's difficult because if we get someone stable on it and then they get ready for discharge, there's like not a lot we can do.
Yeah.
Yeah, exactly.
Interesting. And then you said like the small bowel has the most rejection?
Yeah, they have the highest risk of rejection. I can't remember the numbers, but I think by 5 years, like 90% have had an episode of cellular rejection.
And why?
So it's a couple reasons, but one of the big ones is the amount of like lympholymphatic tissue we
yeah,
transfer over with it. Yeah, so it's like a highly immunogenic organ,
Uh-huh.
but the way it interfaces with the outside world also means it's really high risk of infection.
Uh-huh.
And so the outcomes are just really poor because we have to give you tons of immunosuppression.
Yeah.
So you don't reject, but at the same time, you're high risk of
Like
infection.
anything else,
Yeah. So we actually don't do them here.
Okay,
Yes.
yeah, I never really
I was
heard
gonna
of
say, I
that.
feel like.
Yeah.
Or,
Since
Yeah.
we're pediatric, there are some adult centers that do it, but
Uh-huh.
it's
rare.
a very limited number. Yeah.
And the liver just has the best outcome.
Not like I guess they do have one of the longer longevities, but they just tolerate the lowest levels of immunosuppression overall. Yeah. So hearts, for instance, the median survival is 10 to 13 years.
Mm-hmm.
So by that
Really?
time period, yeah, 50%. So, but we have lots of folks, right,
Yeah.
who live much longer than that, but it's weighted by the people who don't survive quite that long.
Yeah.
Lungs are the shortest. I think lungs might be 5 to 7, but don't quote me on that. I
Yeah.
can never remember. Yeah.
Thank you.
Yeah, you're welcome. Any questions? I don't know if the chat, I didn't see any. No.
No
All right.
questions there.
Great, sweet.
Thanks.
All right,
Thank
well,
you very
thank
much.
you.
Thank you. Interesting.
Yeah, very.
I like these things.
Well, curate me if you have questions in the future.
Yeah.
Never want to do anything that doesn't make sense.